and we'll be live.
Okay, just start.
Yeah, it's live.
Ajay, unmute yourself. Ajay, you have to unmute yourself. Dr. Ajay? Yeah.
Hello.
I think
Good evening, everyone.
is there.
On behalf of Prayagraj Orthopaedic Association, I would like to invite seniors and colleagues to webinar on patellofemoral issues. I thank and congratulate AAUP for taking this monthly initiative. Today we have some of the great and experienced faculties from across India. We are fortunate to have with us Dr. Raj Kumar Amaravati sir. He is a great academician with more than 50 publications, and he is very experienced arthroscopy surgeon. I'm sure AUP members would be highly benefited from his vast experience. We are also fortunate to have with us Dr. Debashish sir. He is great teacher, my mentor and guru. Under him, I have learnt basics of arthroscopy during my residency period. Dr. Rajeev is my friend from my residency days, and he is very young and dynamic surgeon. And Dr. Pranjal sir, definitely it does not require any introduction. He has innovated his own implantless basket wave technique for MPFL reconstruction. Definitely we are eagerly waiting for his lecture. Now I would invite Dr. Ashish sir to say a few words and start the proceedings. Dr. Ashish sir.
Thank you, Ajay. And we all know each other, and we all are well aware of the nice work everybody is doing. And you have nicely introduced each and every of the faculty, and we are quite close to most of them. Of course, not with Dr. Pranjal. I am not very much close, but we will get like this, and it's a now we are having a good association of arthroscopists of our UP, and Dr. Vinay Pandey is very well doing his job, and you all are contributing to this. So I'm welcoming all of them, and Dr. Raj Kumar, Dr. Rajiv, Dr. Debashish, and Dr. Pranjal, and let's go ahead with the seminar, and we will all be benefited by this. Thank you very much.
So the first talk is by Dr. Rajiv on first time patellar dislocator. What is his way of managing this problem? Dr. Rajiv?
Yes, Vinay.
Okay.
Thank you, Vinay.
Go ahead, sir.
For invitation, and I would like to thank the AAUP and Prayagraj Orthopaedic Association for invitation. So my talk was second talk. I think Raj Kumar sir will join a bit late. So I will be talking on first time patellar dislocator. How do I manage? And this is very important aspect because like first time shoulder dislocation, there are lots of treatment and dilemma in treatment modalities. And I will discuss one by one. What are the dilemmas? What are the controversies? And what is the consensus for the first time patellar dislocator? So primary patellar dislocation, as you can see, normally you get in your clinic, the patient with a reduced patella with a hemarthrosis inside the knee joint. And very rarely you get a dislocated patella because of the muscle pull and the contraction of the muscles and the tone of the muscle. Most of the time it dislocates and relocates with the flexion of the knee. And very rarely it comes in your OPD with a permanent subluxation or dislocation when you have a huge osteochondral fragment there. So when you get such type of patients, I think in left side, if you get this type of patient with the acute dislocation, you should know how to reduce it. So try to reduce it under anesthesia inside the OT and relocate it, and then in second part, you can plan your primary management, what is whether you will go for surgical or operative management. But if you get a patient with a hemarthrosis, as you get it in the right picture, I think you should suspect two things. First thing is most of this patient with a mild hemarthrosis is having an isolated MPFL injury. And most of the patient, if you see there is a tense hemarthrosis, these patients are having an MPFL injury with a osteochondral defect also. So why we are in dilemma? Because if you see in your clinical practice, most of the patients are of adolescent age group 10 to 17 years, and you have lots of questions from the parents. So the patella is dislocated, what should be treatment? Whether we should go for surgery or not? What is the chance of recurrence? And you have to answer every question to them. And if you see the literature, the recurrence rate is around 15 to 40% in first time dislocator. But to be very true, recurrence is an exception, not the rule. And even you treat them conservatively, 58% of them are sometimes symptomatic. It's not like dislocation, but they have the symptoms of subluxation there in the knee. So what is the most important part is the initial evaluation of this patient. So here lies the importance of the history. And most of this patient you see in your clinical practice either had a sports injury or there's a history of dance. Yeah, if you see the total incidents, most of them are because of the sports injury, or sometimes because during a practice or during dancing, they may have a twisting injury of the knee with a patellar dislocation. The second important part is clinical evaluation. That includes your evaluation of the knee joint, evaluation of the medial patellofemoral ligament. You have mild hemarthrosis there. Then it's most of the time it's an isolated MPFL tear. If you have a tense hemarthrosis, it's a OCD. Sometimes it's with a MPFL tear with the osteochondral defect. And always see for the lower extremity alignment. One very important point to be noted is history of contralateral patellar dislocation. Suppose patient has presented to you on right side of patellar dislocation, the history of left side of patellar dislocation also, the chances of recurrence is 6 times high if he has a history of contralateral patellar dislocation. And this is very important point to take in history. Tense effusion, as I told you, most of the time you have a tense effusion inside the knee. It's because of hemarthrosis from the MPFL tear, also because of the hemarthrosis from the osteochondral fragment. And that give you a suspicion, yes, this patient may have some amount of osteochondral defect, and you should evaluate it in your imaging, either X-ray or MRI. So normally routine imaging, we follow a routine protocol of AP and lateral view, but most important component in the axial part, because most of this osteochondral fragment either lies in the suprapatellar arch or the medial and lateral gutter of the knee joint. And if you see MRI, it is the gold standard, because you will see the associated injury. You can see the associated MPFL tear, whether it's on the femoral side or the patellar side, and you can locate your osteochondral fragment. Regarding incidence of articular cartilage injuries, if you see first time dislocator, 95% of this patient will have some amount of articular cartilage injury. Either it's like a abrasion of the cartilage, there is a linear streak over the patella or the cartilage, or sometimes you may have a large osteochondral defect with or without a subchondral bone. So always plan for an MRI in this patient, because it will help you in assessment of the tear, whether it's a patellar side tear or it's a femoral side tear. Again, it will help you in locating the loose body. Sometimes you may get a loose body in the suprapatellar pouch, or sometimes you may get it in the medial or lateral gutter also. And this will help you in planning of your management also. So most of the time, after doing a routine X-ray, don't forget to go for an MRI, because that will help you in the planning of your future planning of management also. The first controversy with first time dislocation, whether you should go for arthroscopy or not. So believe me, my friend, and it was a consensus group in 2003. There was a international patellofemoral group meeting headed by Dezor, and they pointed out and they gave a suggestion, and there was a consensus among the X-ray. Yes, if you don't see any osteochondral fragment or there is no osteochondral defect after first time dislocation, routine arthroscopy is not indicated. So don't go for a routine arthroscopy for first time dislocator. This is in our first consensus from that international patellofemoral. Second controversy, and I think this is a very valid controversy, whether you should go for a conservative treatment or a operative treatment. Again, $1 million question, and we have been treating them conservatively. And what are the indications for conservative treatment? First time dislocator, yes, most of us treat them conservatively. If there is no history of contralateral dislocation, chances of dislocation is less, so treat them conservatively. No osteochondral fragment, you can treat them conservatively. And most of this patellar side tear, you can treat them conservatively. They do well with conservative treatment. So how do you treat conservatively? The standard recommendation is put them on 4 to 6 weeks in extension knee brace. Nowadays, we don't put them on plaster, put them on extension knee brace for 4 to 6 weeks. Operative treatment, there is a cartilage injury. And normally you have an osteochondral defect. So your two options, either to repair or remove. A cartilage with a subchondral bone, always try to repair. A cartilage without subchondral bone, yes, you can remove that cartilage. So that is important. Whether you will keep that cartilage fragment there or not depends upon the amount of subchondral bone which is there or not. Normally, the standard recommendation is 8 to 9 millimeter of subchondral bone. If it is attached with the cartilage, try to repair it, either with a biopin, a bio screw, or with a suture pull-out technique. Operative treatment, and for operative treatment, I am pointing toward the MPFL repair. When you will plan for MPFL repair first time dislocator, in some cases, when you have a femoral side tear, not the patellar side, femoral side tear, yes, at the level of the adductor tubercle, you can fix it with some amount of any type of suture anchor, because recurrence rate is less when its tear is at the patellar side, but the recurrence rate is high when the tear is towards the adductor tubercle or femoral side. History of contralateral dislocation. Again, if the patient has a history of contralateral dislocation, the chances of recurrence is 6 times high. And if you are fixing the osteochondral defect, you can repair the patellar attachment during your medial parapatellar approach. So these are the conditions where you can plan for the primary repair. And if you see the literature review, there are various opinions. Sometimes they say conservative treatment, the chances of redislocation is 27% compared to operative treatment. And if you see the other contralateral side, you can see there is no difference of redislocation whether you treat them conservatively or operatively. So what should be the consensus for the first time dislocator? So let me explain it a simple way. Most of this dislocator, when comes to your clinic with a tense swelling, always suspect for an osteochondral defect. If there is a tense effusion, evacuate the hematoma for pain relief. If you have an osteochondral fragment, whether to fix or remove it depends upon the subchondral bone is attached with this fragment or not. If you have 8 to 9 millimeter of subchondral bone attached with that cartilage fragment, always try to fix it. Now the main dilemma lies whether we will go for an MPFL repair or not. MPFL repair for femoral side avulsion, yes. Now it is recommended if it's a femoral side avulsion at the level of adductor tubercle, try to repair it with the suture anchor. But MPFL tear with a patellar side tear with no OCD, always try to treat them conservatively within 4 to 6 weeks in the extension knee brace. But MPFL tear with patellar side plus OCD, again, there are two schools of thought. You can repair it over the patellar side while you are after repairing your osteochondral fragment, you can repair the patellar side to tighten the medial patellar side, or just after that you go for a routine closure. Don't go for apply any suture anchor or tightening of the medial patellar side. Go for a routine suture, and chances of recurrence are low if you repair them when you are fixing the osteochondral fragment also. So thank you, and think these are the important points you should know. What are the indications when you will suspect that there is osteochondral fragment there, and when you will plan for your OCD repair, and when you will plan for your MPFL repair with the OCD repair.
Thank you, Dr. Rajeev. That was a wonderful talk. So we are going to take the questions at the end of the session. So is it okay, Ajay? So we take questions at the end of all the 4 lectures. So now we go to Dr. Raj Kumar Amaravati, sir. Dr. Raj Kumar, are you there? Dr. Raj Kumar, sir, are you there? So if Dr. Raj Kumar is still not there, I think we can start with the Debashish sir lecture. Debashish sir.
I think Yes, I'm ready, but
Yes,
it
sir.
looks like, yes, Dr. Raj Kumar has joined. But anyway, I can start. I don't mind.
Dr. Raj Kumar, are you there, sir?
Yes, she's there.
You're there. Raj Kumar, sir, good evening.
Haji.
So we are ready with your lecture. Are you there?
Yeah, I'm there. I'm there.
So we can start the talk right now.
Okay.
Dr. Rajiv, in between there is a question. Can I ask?
Yeah, please.
So is there any approach in the difference of approach when you see an osteochondral defect on the femoral side versus on the patellar side, or the treatment protocol is same? Do you make any difference in rehabilitation protocol, especially with the patients?
The
after fixing?
OCD on the femoral side, if it is, you can fix it arthroscopically also. But when it is on the patellar side, most of the time we go for a medial patellar parapatellar arthrotomy and fix it. Again, for rehab, I think any repair either or femoral or patellar side, you should be slow in rehabilitation in these patients. So now normally we are not very aggressive in rehabilitation.
Also, can I come in, Rajiv?
Yeah,
There
please.
is another shorter answer to this question. The thing is, the osteochondral fracture from the femoral side is extremely uncommon. It is almost all the time from the patellar side.
Yes, sir. Yes, sir.
On the
Agreed.
LFT, you will see a bone bruise. Honestly, I'm here for 25 years practicing in single osteochondral fracture coming from the femoral side.
Yes.
I'm sure the other people will tell their experience.
Definitely, sir. We have never seen osteo in first time dislocated fragment on the patellar side, femoral side. It's most of the time it's on the patellar side.
Ready, so I will leave it now. I'll mute my.
Raj Kumar, sir, you are here.
You are seeing my screen, Rajiv?
Yes, sir.
Yeah,
But make it, sir.
Now?
Yeah, it's
Yes,
PowerPoint
we
now.
can see it.
Presentation mode, yes, sir.
Okay.
We can see. Carry on.
Thank you so much. And yeah. So I thank Dr. Vinay and his team for having me for this wonderful webinar. And I'm sorry that I had to rush to come for the meeting because I was caught up in the traffic. And here we go. Anterior knee pain, or otherwise called as a patellofemoral pain syndrome. There are many synonyms to it, but we don't want to dwell on that, but we'll concentrate for this meeting on anterior knee pain and its intricacies. My charge today is to talk mainly about the management of anterior knee pain. But before going into that, over the next few minutes, I'll be talking on how this evolves, and then I'll give you my thought process on how we manage the anterior knee pain, both conservatively or by physiotherapy or by some surgical means. It is the most common condition, but as all of us are practicing knee arthroscopy surgeons or some kind of knee surgeons, there is no consensus on how exactly this condition has to be managed. And this is based on evidence and some not on the evidence. There are very minimal interventions that have been mentioned in the literature where there is evidence to take care of the pain and its function. Taping, yes, is not a panacea for all anterior knee pain, we should know. And there are exercise-based interventions that will definitely help the individuals over a long period of time. And what are those exercises? We'll see in the next few minutes. There are two thought processes that run into how the anterior knee pain evolves. If you have to break down into a proximal problem, and that usually involves the hip abductors. And if we take, there is a local problem that is in the knee, it can be either because of the quadriceps tightness or in the hamstring tightness, or it can be because of patella hypomobility or hypermobility. Now, there are different ways to assess this. It can be assessed manually or by handheld dynamometers. you can see that there are for different age groups and different level of individuals, the values are given there for you to see. The threshold for having an instability or for having pain is different for a male and a female. But if you are hypermobile, the indices for having the instability or the pain is little higher than the people who are hypomobile. Now, when we classify this patellofemoral pain syndrome, we generally say that if it is only a lateral compression problem or it is a global problem for the patella, it can be also broken down into a problem that arises because of the instability of the knee. It can be because of a tracking or subluxation or dislocation, or it can be a biomechanical dysfunction, which can be all the way up to the hip, to the knee, or even in the ankle. A direct patellar trauma can involve damage to the cartilage, which can present as an anterior knee pain. Soft tissue lesions, especially the plica or the contracture of the fat pad, IT band contractures, or the MPFL lesions can also present as anterior knee pain. Of course, tendinopathies and epiphysitis. Tendinopathies basically in the seronegative arthropathies can present as anterior knee pain. Now, what a malalignment or muscle imbalance can cause to the knee is, it can cause either a static problem or a dynamic problem. Static problems are basically because of limb length discrepancies or dysplastic trochlea, or torsion or rotational problem in the lower limbs. Dynamic problems are basically because of muscle imbalances or muscle weakness. Even the playing surface on which an individual runs or plays can influence how much traction is there on the knee, or how much force or how much pressure is applied across the axis of the lower limb. Overactivity or overload. This is the main cause for the anterior knee pain that the literature says, and it is because of the increased workload that sometimes an individual takes up when he has to perform for a particular game, or when he's preparing for a particular activity, or if he is really a fitness freak, he can really overload the knee and get injured easily. And what exercise regime does he follow, which involves more squats or those kind of thing, and if he's doing it not right or in an appropriate manner, he can have these issues. BMI, yes, it should be less than 25. More than 25 generally are prone for these kind of problems. If we go by epidemiology, we can see that in the year 2022, the articles written on the anterior knee pain or the influence of the problem in the society is phenomenal. If you see that during the COVID period, that was not much, but as the people have moved out of the COVID and started working, from being sedentary to now working, walking, running, jumping, trying to be fit, they have got more anterior knee pain now, and you can see the number of articles in that year is increasing now. So the age group where the people are involved is basically adolescents, more women than men, and it accounts for 25 to 40%, and that is a huge number. If you see that these individuals who are involved in the third decade of life are facing. Now, how do they present? There is no set pattern how it presents, but generally all of us know that it is also called as a cinema sign or a theater sign when we sit for long hours watching a play. But it is very diffuse and very vague, and there is no exact clinical finding to say that this is how anterior knee pain presents. On physical examination, we generally have to look closely at the VMO. We also have to rule out the quadriceps tightness by putting the patient into prone position and trying to flex the knee. If the quadriceps are tight, then the heel will not reach the buttocks, and that will be found lagging. It is a useful test to do Clark's test, wherein normally one finger breadth of your thumb will rest on the lateral femoral condyle and the patella is mobile. If the patella is not mobile and it is very tight and you are not able to place your thumb, then there is some amount of tightness in the lateral retinaculum is an inference there. You also should do in all OPD procedures examination of hyperextension of the knee unless the patient is hypermobile. If you can see here, the right knee is a little tight compared to the left knee, which is normal. There is 0 to 5 degree of normal hyperextension. If that hyperextension is not there, then there is a possibility that there could be something happening around the patellofemoral area. Also, if you can see here in a straight leg raising, you can look for the hamstring tightness. Sometimes if there is bowing and the patient is not able to completely do a good flexion of the hip with the knee extended and complains of pain in the back of the knee, excluding the spine problem, hamstring tightness can influence the patellofemoral problem. Even the abductor and adductors of the hip have to be checked. If you can see the tracking of the knee here in this knee, the patella is good. Okay, but if you see in this knee, it is almost similar, but you can see that the patella jumps. It is subluxating, but it is not dislocating. Patient may not come to you and tell that, you know, the patella has ever dislocated. But when you look at the way the knee moves and tracks in a regular OPD, you should be able to pick this up, and this could be a cause for his anterior knee pain. The usual investigations that are done in all clinical practice is an X-ray, but in anterior knee pain, generally, you will exhaust all your conservative methods of managing the patient by medication and all those things. Over a period of, say, 2 years, they say in the literature, you have to exhaust all your management, and then only you go ahead and do X-rays. But X-rays are of great value if it is a unilateral problem, because you don't want to rule or miss out on any tumors in the knee or any kind of a cartilage lesion. But if at all you prescribe an X-ray to a patient, you make sure that you have a good lateral X-ray, good tunnel view, a great skyline view to see that the lateral part of the facet of the patella is not impinging on the femoral condyle. MRI, cardiogram, ultrasound, and inflammatory markers will add value to your diagnosis of anterior knee pain. Now, non-operative way, as I said, everybody will be prescribing patients with initially non-steroidal anti-inflammatory drugs. Icing and bracing and taping, as I said, would be a part of managing these patients. However, activity modification and reduction of the BMI are the key to, slow down the way the patient presents with pain or anterior knee problem. What are the exercises to avoid? Especially lunges and squats and stair stepper and leg extensions are to be avoided. Deep squats is not a good way of taking care of the knee when it is paining. And how you do your lunges, it is important that your body is aligned to the lower limbs and is straight, and you don't lean forward when you're lunging. The rehabilitation principles to begin with in the management of anterior knee pain. Our core idea is to reduce the pain, restore volume control of the muscle, emphasize mostly on the quadriceps. We need to restore the control of the knee, but the management will go up to managing how the hip also influences the knee function. The soft tissue should be made flexible. We should improve its mobility. We also should work on how proprioception and neuromuscular control of the knee should be established. It should be a structured return to function. So these all, if we do in a stepwise fashion and in a coordinated fashion, we'll be able to give a good outcome to the gentleman. Now, what is the cause for the pain? Why pain occurs in anterior knee pain? If you see the structures that are there around the knee, there are around 6 structures that give rise to pain: the skin, the muscle, the fascia, the subchondral bone, and around the cartilage and the synovium. Pain can arise from any of these, but if we control these envelope, that is the milieu of the knee, in a good fashion, not stressing the knee as the graph shows here, then we will be within the area where the pain arises, so that we will not stress the body to go above the supraphysiological level. But if we cross the supraphysiological level by repeatedly, causing trauma to the knee, if you can see the frequency where the knee can be subjected to stress and strain increases, and then we have to rely on, medications and different way of exercises, taping and braces to manage our pain. So exercises, when done, or activities done within the physiological loading, are acceptable, or slowly build on to reach a level where it is supraphysiological but not amounting to trauma to the knee. It is important for us to prevent any inhibition in the quadriceps and keep the VMO and the quadriceps functioning optimally. How we can do that? We can do that by stimulation of the neuromuscular stimulation of the quadriceps muscle, so that an important biofeedback establishes between the knee and the brain, and then it can function without any inhibition. These inhibitions are commonly seen when we do our arthroscopic surgeries around the knee. The latest concept now is why the quadriceps doesn't come back to its normal girth after an ACL surgery is the biofeedback from these neuromuscular receptors don't reach properly the higher centers, and that is when the quadriceps is inhibited to function normally even after you have reconstructed the ACL. So now we have to work at the next level, that is a higher level, to make sure that the quadriceps girth can be retained or can be stimulated to come back, provided we take care of the higher centers also. We should emphasize on the functioning of the quadriceps. As I've told you, how we do that, we do quadriceps strengthening through the closed chain and the open chain kinetic exercises. But remember, without adding any adduction or internotation during the movement. And there is no resisted short arc quadriceps movement, because that will cause more patellofemoral compression and increase in the pain. The joint reaction forces increases when you do short arcs, and make sure the open kinetic chain exercises should be avoided in these range of movements, and avoid deep squats in closed chain exercises. Cycling, leg press allowed, wall squats are allowed, mini squats are allowed, split lunges to be done, and side stepping step ups should be done, which will help in taking care of the knee mechanics and the pain in the knee. We know that wider pelvis is always blamed for most of the problems in the knee, but that is not the cause here. It is generally due to the weak abductor strength that the knee can have pain. We start addressing that, increasing the strength and stability, and then bringing the dynamic control over these muscle groups so that it is controlled well in acceleration and eccentric deceleration. Humans generally function in a 3D mode. See, for example, you see this gentleman or the lady descending down the stairs. You can see here that the limb is adducted at the hip, and it is flexed, and it is internally rotated, where the knee is going into valgus. That is how the knee generally functions. And the patella and the femur control on the knee should be balanced. The movement is taking place both in the sagittal plane as well as in the flexion. So we need to work on these mechanics so that we are aware how the knee functions while we ascend or descend the stairs, and take care of the affections. Here you can see an individual, how the hip influences the mechanics of the knee. We are not supposed to squeeze the ball that is there between the thigh like that. You have to just control the mechanics so that you can build your abductor strength using the TheraBand or this kind of a mechanics, wherein you can challenge your body not to lose the ball between your legs, or you can build the strength and the coordination between the hip and thigh muscles by doing TheraBand exercise in this fashion. Why we have to improve the flexibility of the tissues? It is to reduce the risk in an athletic population and take care of the faulty biomechanics that will influence the kinetic chain, which will become a cycle for him to have pain over and over again. So here, if you can see that this is a normal knee, this is the knee where the mechanics are slightly changed, as a result of which you can see that the lateral patella is more impinging on the condyle here, the lateral facet. In this case, the total quadriceps mechanics itself is not at alignment. You can see that the Q angle is changed, and that is the reason again we can find that the lateral facet of the patella will impinge on the femoral condyle. So trying to find out what exactly causes this problem is the crux, and it is not always the IT band. Remember that it is not always the IT band that is in question. We have to look at globally what are the structures that influence the knee mechanics, and then take a call. Remember, the source of pain in the patellofemoral area is not to be from the articular cartilage. As I said in the beginning, there are structures that usually give rise to pain. They can be from the subchondral bone, the retinaculum, fascia, synovium, skin, nerve, muscle. So all these will contribute to the pain in and around the knee. So try to evaluate which exactly is the culprit in causing this problem, and then try to manage accordingly by mobilization, facial manipulation, taping, and bracing. Proprioception and neuromuscular control is important because there is a neuromechanics, there is a hypothesis that, if these mechanics are not set right, there is a possibility that the muscular control around the knee will not be appropriate. A dysfunction of the vastus medialis, everybody knows, can give rise to a problem in the patellar function. And injury prevention and performance improvement should be the focus for us to take care of the pain that is there in the knee. If knee pain is not controlled, the performance and the amount how they perform will be reduced, as a result of which, how we do that and how we take care of that, we need to promote squatting on an unstable base to improve the proprioception and neuromuscular control. How we do that is in this fashion. You can initially start them weight bearing with the TheraBand with the blindfold, so that you can challenge the body to be stable like that, and you can then challenge them to be on an unstable surface, both with the TheraBand and without a TheraBand, single leg stance or on a double stance sometimes. You can see here the patient is doing a blindfold stand on a trampoline, which is an unstable surface, as well as she is doing on a system where it is unstable. So thereby you challenge the muscles to hold you steady and build the neuromuscular control across the knee to give you a good biofeedback to be stable in a situation wherein you are challenged. Surgical options that are to be mentioned here for closure, because surgical options are being spoken by my other colleagues, especially the MPFL that everybody knows is a cause for the patellofemoral displacement or dislocations. Tibial tuberosity transfers, bony procedures, or torsional deformity correction is an option to reduce the anterior knee pain if it is required. Resurfacing arthroplasty is coming in a very big way to take care of the patellofemoral problem. So finally, what are the treatment guidelines? To take care of the patellofemoral compression, we need to do a proper articular and soft tissue mobilization, especially using heat and taping to prevent the soft tissue creep. If there is a global way of having a patellofemoral problem, it's try doing more exercises in the pool, which is less stressful on the knee. Avoid activities like cycling and stairs in this situation. If instability is the cause for pain, then we give initially a static problem. If it is a static one, then we give bracing. A dynamic problem, we try to work on the neuromuscular control of the patella at the knee as well as the leg as a whole. If it is a biomechanical dysfunction, whether it is at the foot or the ankle, especially if the foot is more pronated, there will be more stress on the knee. So we have to work on those situations and work on the hip abductor strength as well as the hamstrings, and then try to set right the mechanics. If it is a direct patellar trauma, initially try to promote the cartilage healing and controlled level of stress. And then if you think we are not able to manage, then refer to a person who deals with the cartilage appropriately. And that is the upper limit. So there your management of doing conservative for the anterior knee pain stops, and you should be forthright enough to send the patient to referral to handle the cartilage problem, which is beyond the scope of managing just by exercises. Yes, if plica is a problem or IT band friction is a problem, improve the flexibility, improve the quadriceps. And if fat pad contracture is there, mobilization of the fat pad is very, very important, because it is commonly seen, especially after ACL surgeries, wherein we see that the patient keeps on complaining of pain in the knee. And that is the reason wherein if the fat pad is contracted, there won't be any hyperextension of the knee, which is a very simple test to do in a practice. If hyperextension of the knee is not there post ACL surgery, kindly look at the fat pad, because it would be contracted because of more of shaving or when we use a cautery. And it should be restored to the normalcy. If that doesn't restore, then the patient is unhappy. Overuse syndrome should be avoided. You have to correct all the errors that are there in the biomechanics of the knee that are faulty. So the take-home message would be, understand where the pain is coming from, what is the source and what is the mechanics of it. There are clinical groups, not everybody is the same. Apply biomechanical and neuromechanical principles in rehab. we need to stop focusing on the symptoms because they are not specific, they are very vague. So try to be a good clinician when you try to treat patients with anterior knee pain, because there is no one answer to manage anterior knee pain. Thank you so much for your patient listening. Thank you so much.
Thank you, Raj Kumar, sir. Absolutely wonderful presentation, very elaborative. So we will keep the question at the end. Debashish, sir, can we move to your presentation?
Yes. So am I to share my screen? I think Dr.
Yeah,
Raj Kumar has to log out first. Yes, I think that's done. Right. Right. Is my screen visible?
Yes, sir. We can see your screen.
Right.
Perfect.
My assignment has been to talk about recurrent patellar instability management algorithm. It's not easy, more so in the last 10 years. I will tell you why. But before that, talk briefly about the types of instability that we see in our clinic. Firstly, is the traumatic dislocation. Rajeev has talked about it, which is acute, by definition, one-off, and severe trauma. And often, or not often, they may be associated with osteochondral fracture of patella. But the trouble is, traumatic dislocations are also the first episode of a recurrent dislocation. So you have to. The second dislocation, we used to see the 20, which is a painless of the patella with every knee flexion, every bent his knee, the patella subluxus. And it is due to a fibrotic lateral band, which may be congenital, but previously it was more due to typical injection fibrosis of the vastus lateralis, where people used to have their injections in the. It would be a young adolescent boy, and this habitual dislocation patients, they are painless. They will bend their knee every time and dislocate, no problem. Last but not the least is the recurrent dislocation, which now form bulk of our patients are episodic. They happen beach, time and again, not every day, not every reflection. But they happen with minimal or no injury, unlike ligamentous injury, for example, coming down from twisting my knee in the toilet. This sort of minimal or no injury typically causes recurrent dislocation. The patients will have a tender medial facet apprehension test would be positive, and they are often associated with generalized laxity and more common in females. We'll talk about that. What are the causes of this recurrent instability? It has been shown that soft tissue deficiency medially is the commonest cause. First is the MPFL, medial patellofemoral ligament tear or injury, which actually is the most important medial stabilizer of the patella, giving it a strength and stability during the initial 30-40% of the knee flexion. Second is a VMO weakness, which can be either dysplastic or it can be by repeated dislocation, subluxation, stretched and wasted. These soft tissue deficiencies are commonest. Less common abnormalities. Number one is, of course, patella alta, where a high patella cannot engage in the trochlea, so more likely to get unstable, or there is a more increased laterally directed force on patella. We'll talk about that later. And last but not the least is trochlear dysplasia or lateral femoral condyle hypoplasia. There are also some general causes of recurrent patellar instability, of which most important is the limb alignment issue, the increased femoral anteversion, increased tibial torsion, the high amount of genu valgum, excessive foot pronation, etc. But how much they contribute individually is a question, definitely. But they contribute. And the patellar hypermobility, oftentimes these patella are more hypermobile than the other one. And there would be generalized ligament laxity in such patients also. So how do you evaluate them before you come to a management algorithm? Of course, history. Typically, the patient give history of a feeling of giving way. Not exactly, they say always that there is dislocation. Dislocation is a more dramatic event. More often than not, subluxation, they say it's a sort of give way with minimal or no injury, just twisting, turning, etc. And there would be pain or swelling followed by this give way. An astute clinician must. There could be locking or catching like symptoms, but much less common. On exam, the patella is. There would be facet of patella, especially after a recent instability and apprehension test. And then after this clinical examination, you go to the. But before that, you also see if the patient has got laxity, mobility already tracked. The patellar tracking, including the J sign, the Q angle thing, we'll talk the overall limb alignment, including femoral anteversion, and going into how to check that. The foot and the heel alignment, all these you need to check. And then you do your simple investigation like an X-ray. An AP and lateral X-ray gives you quite a few information, including presence of, including the trochlear status, we'll talk about that, or any bony injury, including osteochondral fragments, etc. Then the skyline view of the merchant in 45 degrees, and the weight bearing AP or the scanogram to see the overall alignment. These are the X-rays. From the lateral view, what we see is the patella alter, the patellar height. There are different ways, the insult salvati or the Blackburn pill. I find this Blackburn pill more convenient. The joint line to the lower border of the articular cartilage and the length of the articular cartilage. This lower B by A normally is about 0.8 to max 1.0. If it is more than 1.0 to 1.2, then you definitely have a patella alter. Also, from the good quality lateral view, you can look at the trochlear, possible trochlear dysplasia, especially the supratrochlear spar, the crossing sign, double contour sign, etc. But mind it, for this you need a very good quality lateral view, which should be exactly lateral. That means that the two condyles should be exactly in line, and du jour recommends taking this X-ray under fluoroscopic control. Unless this thing is corrected, then you will not be able to comment on that. But anyway, I'm not going to comment on that because I'm learning that myself still. MRI is very important because now diagnosis by excluding other things, and number two, it confirms. And it has been said that there are these 4 or 5 common MRI findings, of which if there are 3 or more present, then you can diagnose that to be a MRI, the diagnosis of patellar instability. Number 1 is joint effusion. You can see the fluid level here. Lateralization of the patella on the trochlea. Contusion of the lateral femoral condyle. This happens when the patella tries to re-enter after a dislocation, and also of the medial facet of the patella. Medial facet of patella and the lateral side of the lateral femoral condyle. Or if there is any osteochondral fragment, or if there is a MPFL tear. Any 3 of the 2 will give you a diagnosis of patellar instability on the MRI. 3D is basically needed this 3D CT is basically needed for trochlear diagnosis, trochlear dysplasia identification and classification. Generally, it is less necessary. Next important to evaluate is the lateralization of patella. As you see, this Q angle is a crude thing where you basically draw a line along the anatomical axis of femur and the anatomical axis of tibia, and this angle in between is known as the Q angle. Of way of doing that is by measuring the TTTG, tibial tubercle trochlear groove distance on CT or MRI, and normally which is about 13, a distance more than 20, realignment correct. Talk about that later. For those interested, I'm just briefly telling you, this is how the on the soft tissue on the software, the lower end of the femur and the upper end of the tibia, and then you first as a base connecting the lateral posterior border on vertical to the center of the trochlear groove, then center of the tibia, distance in between is. So that is how it is done. But so with these informations in hand, now you are asking for the decision what to do. First episode of the acute traumatic patellar dislocation, or the first episode of as Rajeev said, the treatment is conservative. Treatment is conservative, non-operative, unless the general fracture body, then you have to intervene. Or there are certain cases, especially people with a contralateral knee problem. If the patella is also subluxated on this knee on MRI, then you have to possibly intervene early. And avulsion of the MPFL, as Rajeev said, is also a surgery. But these are commonest indications of condyle fracture. Unless it is there, we manage the first time dislocators conservatively. On the other side, the treatment for recurrent dislocation of patella is surgical. The role of non-surgical management is basically very limited. Maybe for the first time dislocator, maybe for people with minimal symptoms, maybe when the patient refusing initial surgery, etc., etc. But generally, treatment, when it is recurring, the treatment is surgical stabilization. Surgery aims to recreate the medial stabilizer, which is the medial patellofemoral. Only in limited cases with osseous deformity, a bony requires. Now we'll talk about that later. But MPFL reconstruction technique, I'm not talking, Pranjal will talk after me. The grafts available are semitendinosus or gracilis, and also the superficial quadriceps tendon. I use this like as recommended by our friend Deepak Goal. Walking through a tunnel, anchors or Pranjal's method of basket weave thing. And fixation of femur is by transfixation or interference screw. I use interference screw. What about the osseous realignment? This is necessary only in cases with osseous abnormalities. So they are not very common. Soft tissue surgery is more common. What are the options for high patella or patella alta? You distalize the tibial tuberosity. For a lateral patella, that is increased TTTG distance or our old Q angle, increased TTTG distance, you medialize the tibial tuberosity. And for trochlear dysplasia, we need to do a trochleoplasty. Let us take them one by one. This first two, the hypatellar distalization or the medialization of tuberal tuberosity for TTTG distance, these two together are known as distal realignment. The traditional good old procedure is Hossa's procedure, where you medialize the tibial tubercle, the initial Hossa's description, or you can distalize also if necessary, but they are supposed to cause increased patellofemoral contact pressure by medialization because of the triangular shape of tibia. So Emsley-Trillat came up with an design where you do the medial shift of the tibial tuberosity without Falkerson osteotomy is a modification of Emsley-Trillat, which also allows anterior shift, but it is a horrendous operation. I have few examples, few experiences in UK. Never have touched it in. For all practical purposes, realignment is a shift for most of the cases. Now the trochlear surgery. As we know that elevated lateral prevents the lateral. Dysplastic trochlea or flat or even convex, ineffective in construction. So Alvey did a early of 1950 Russia, but then people forgot about it because of technical difficulties, complications, and it being an open with its attendant complications, etc. But then in 1994, Guy Walsh and his guru Dejour, they together reported that in about 80% of 85% of individuals with stability, there is a varying degree of trochlear dysplasia. So people then had in trochleoplasty and things. In 2010, the David Dejour, the son of the original Dejour, and Sachin, they described 4 types. The father described 3 types. He included 1 more to complete the list. And then different surgical techniques for trochleoplasty started welling up. Just briefly, these 4 types of these trochlear said. Type A is the shallow trochlea with sulcus angle widen up. Type B is this flattened thing with this Type 3 is there is a lateral huge bump, and type 4 there is huge supracondylar ridge and this huge bump. These are the 4 types he has described. And Dejour in 2016, he said that even he was rather skeptic looking that the possible treatment algorithm is depending or this trochleoplasty is for Dejour type B and D, where you depend and make a new groove for the patella, trochlear sulcus, and the lateral elevation and proximal recession for Dejour type C. These are the options he said, but in a multiple reviews, it has been seen that the clinical outcome data is very limited, and it is an open surgery. It's technically very challenging to create the exact congruency and has a substantial risk of complications. And these complications are not small. Patellar, for a patellar instability surgery, these are quite big, including arthrogenic cartilage damage, patellar incongruence, overcorrection, stiffness, arthrophyrosis, and late advanced arthrosis. All these you have to keep in mind when you advise somebody about trochleoplasty. And this is Weber, Alexander Weber, he only 2016 said, currently trochleoplasty should be reserved for surgeons with vast experience in this technique and for patients with recurrent and complex patellofemoral instability, that is after a failed surgery, not for the first time thing. Then there were options for some limb alignment surgeries. Some people preferred them, like medial epiphysiodesis for excessive genu valgum in skeletally immature patients, or derotational osteotomy for excessive femoral anteversion. But then again, they should be only performed in failed, not as a first time thing, for failed soft tissue procedures, or you have to correct together. So friends, coming to the last part of my story. So now on this background, if you see, this is what I suppose should be the management algorithm, and this is what I follow also. MPFL reconstruction should be the treatment of choice in most cases of patellar instability. Osseous should be done only if there is a patella alter, that is more than 2, where you distalize the tibial tubercle, or if there is the more than 20 medialize. If there is, then you do a mix of both. Trochleoplasty is reserved plus or very advanced dysplasias surgery, as visual that for type B and D, the groove deepening trochleoplasty. For type C, lateral elevation or proximal recession. But these are, again, I'm telling, these are for very specialized job with high rate of completion. Limb alignment surgeries are again done very selectively, maybe as a second option in a failed case. So let me repeat, MPFL reconstruction is the management protocol for most. If there is associated distal osseous abnormality like patella alta, then distalize the tibial tubercle. If there is lateralization of patella with TTTG more than 20 millimeters, then medialize. Other options in a failed or a difficult case only. Thank you.
Thank you so much, sir. Very comprehensive talk about patellar instability, recurrent patellar instability. So now I would invite the last speaker for the day, Dr. Pranjal. Are you there?
Yes, I'm here. Just a minute.
So we can proceed with the lecture now.
So the previous one needs to be stopped from screen sharing.
Yes. Hang on, Pranjal, give me time. Give me time. Oh. Why can I not do that? Why can I not do that? Stop share. Yes, I've done it. Thank you.
Yes.
Yep,
Right.
carry on.
One sec. Right. Can you see my screen?
Yeah, we can see, sir.
All right.
Thank you.
Let's see. All right. So firstly, let me thank the Arthroscopy Association of Uttar Pradesh and Dr. Vinay for having invited me to speak on this topic, MPFL reconstruction. And my preferred technique is the basket weave technique. That's my disclosure. So as we've seen in our previous talks, when it comes to the treatment of patellofemoral dysfunction, whether it's instability or pain, it's not just the local factors that we need to consider. It's also things like generalized laxity, abnormalities and deformities in the spine, the hip, right up to the foot and ankle, which have a bearing on the patellofemoral instability, and these need to be addressed appropriately. So with this better understanding of patellofemoral instability, we've moved on from a very simplistic and minimalistic approach which we used to use earlier, like lateral releases and medial plications, to a more customized and holistic approach for management of these disorders. So what we use at present is a multimodal treatment concept, and very often, as we've seen in the previous talk, a bony procedure would be more often than not associated with a soft tissue procedure. And one of the basic soft tissue procedures, as we all know, is an MPFL reconstruction that is done for lateral patellar instability. As far as I am concerned, I prefer to do this technique, the basket weave technique, which I've been doing for the last 12 years, and I've got excellent results with this technique. The technique has been published also in the American Journal of Arthroscopy Techniques in June 2015. The question that one may ask is why innovate and why come up with a new technique when we already have so many number of techniques in literature for MPFL reconstruction, and they do have given good results. But if you were to go into the details of the techniques and the results, you would find that the results have been compromised only because of some drawbacks in the techniques. And the idea of coming up with this technique was to improvise and to remove these drawbacks and give a more reliable and a reproducible technique which can give less complications and therefore better results. So if you were to see where the results and the technique gets compromised is either if the technique is non-anatomical, it could be non-physiometric because of the way you've placed the graft, that is, it does not recreate the normal physiological loading of the patellofemoral joint and the physiological movements of the patellofemoral joint. So it needs to be physiometric. If there are surgical errors from intraoperative use of radiography like the Schottle's point, complications arising from implants, if there are bone tunnels, and morbidity of graft harvest. So you'll see further down in this talk how this basket weave technique manages to overcome all these drawbacks, and that's why I prefer to use this technique. Now, if we were to see the anatomy of the MPFL complex, as it is called now, it is not just the medial patellofemoral ligament, but an MPFL complex, which consists of not only a bony attachment of the MPFL onto the medial border of the patella, but it has a soft tissue attachment as well onto the vastus intermedius. And this is called as the MQTFL, or the medial quadriceps tendon femoral ligament. And when we need to have an anatomical reconstruction, we need to recreate both these aspects of the MPFL complex, that is the bony attachment as well as the soft tissue attachment. If we see most of our reconstructions that have been described, focus only on the bony attachment, and these are rigid fixations using either screws, anchors or bone tunnels. They do not recreate the soft tissue part of the MPFL complex. Therefore, it is a non-anatomical reconstruction when you are doing reconstructions like these. And these cannot recreate or replicate the normal physiometric loading of the patellofemoral joint and the physiological movements. Even in pediatric age group, as we know, bone tunnels are best avoidable near the physis when they are open, and in small patellae as they can lead to patellar fractures. Implant-related complications are known to occur. They could be related to either pain, patellar fractures in cases of bone tunnels, or if you have an infection, you would end up with large bone defects, as seen in this particular case here. Following a screw fixation, you have large bone defects on the patella as well as on the femur. And this needed to be revised using a basket weave technique of the MPFL reconstruction. Very often, we'll end up using radiographic markers like the Schottle's point for the femoral insertion of the MPFL. And this leads to almost a 25% error in your reconstructions. If you were to go into the details of the articles by Schottle himself, you would see that 2 out of the 8 insertion points that were studied by him actually lied outside the Schottle's point area. So 2 out of 8, that is 25% of the cases, you're going to go wrong in placement of your femoral tunnel or the femoral placement of the graft if you were to follow this radiological marker, which is the Schottle's point. So using this radiological marker is best avoidable. What is best suitable is to use reliable bony landmarks, that is the adductor tubercle and the medial epicondyle on the medial side. So these 2 bony prominences are well palpable on the medial side of the femur, and as we know, the MPFL attaches exactly in between the adductor tubercle and the medial epicondyle. This would avoid the error of abnormal placement of the femoral tunnel if we were to use the radiographic markers. So here's an example of left knee recurrent dislocation patella. As you can see, it is dislocatable laterally under anesthesia. Arthroscopically, we can see there is a lateral overhang and lateral tracking of the patella. We do an arthroscopy to manage all the intra-articular pathologies, remove any loose bodies if they are present. Then we go ahead with the graft harvesting. One can use either the gracilis or the semitendinosus. I prefer to use the gracilis in athletic individuals and in adults. In obese females and who are non-athletic, I prefer to use the semitendinosus. A minimum length of about 210 millimeters is what is required. Once the graft is harvested, we prepare the graft on the back trolley and keep it for pre-tensioning. Once that is done, we go ahead with the skin incisions. Now this is a diagrammatic representation of the medial side of the left knee, that is the patella. That is the MPFL in green. That is the adductor magnus attaching onto the adductor tubercle. That is the medial collateral ligament attaching onto the medial epicondyle. And the yellow area marks a ligamento-periosteal tissue area, which is formed by the confluence of all the fibers from the MPFL, the adductor magnus, the medial collateral ligament, and the gastrocnemius posteriorly. So here we go ahead with the skin incision. The patellar incision is on the medial border of the patella, and the femoral incision is over the region of the adductor tubercle and the medial epicondyle. We then incise just the first layer of the medial retinaculum, and we form a plane in between the first and the second layer of the medial retinaculum. As you can see over here, my forceps is holding the first layer of the medial retinaculum, and that is the second layer. In fact, in the second layer, at times you might be able to visualize the native MPFL over there. Once the patellar incision is done, we then go ahead with the femoral incision. We palpate the bony landmarks, the adductor tubercle, the medial epicondyle, and the distalmost margin of the medial femoral condyle. The incision is taken in the region in between the adductor tubercle and the medial epicondyle. We again reconfirm the position of the adductor tubercle and medial epicondyle using our finger palpation, and the region in between the two is then elevated using sharp dissection. So this gives us a very thick ligamento-periosteal sleeve area around which our graft can be looped. So that is the 15 number blade. We do a subperiosteal dissection and elevate about 1 centimeter to 1.5 centimeters of the tissue. Using this mixture forceps, then we loop the pre-tensioned graft underneath that ligamento-periosteal sleeve, and as you can see, it's a pretty strong sleeve to hold the graft over there. We then shuttle the two limbs of the graft using this tissue elevator suture passer. This helps us ease the passage of the graft underneath the retinaculum and even in the further steps of our surgery. So this avoids entangling of the two grafts underneath the medial retinaculum. We then go ahead with the fixation of the graft. So this can be done using a simple number 1 vicryl suture. It is sutured onto the ligamento-periosteal sleeve area, and then we suture the first layer of the medial retinaculum onto it. So that completes our femoral fixation of the MPFL graft. We then go on to the patellar side. On the patellar side, we need to elevate alternate sleeves of extensor retinaculum in 2 rows. The proximal row is at the level of the superior pole of the patella, and the distal sleeves are at the level of the middle third of the patella. So that is the first proximal sleeve being elevated there. I use the tissue elevator suture passer again to help us in easing the passage of the graft underneath these sleeves. So as you can see, just with one single step, you are able to dissect as well as pull the graft underneath the sleeve. So that is the second alternate sleeve that is being elevated. Again, the tissue elevator suture passer being used over there to ease the passage of the graft under the sleeve. Now the distal row, as you can see over here, this is at the middle third of the patella, the medialmost sleeve being elevated and the graft being shuttled under it, and this is the other alternate sleeve in the distal row. And once that is done, you can see a basket weave kind of a pattern on the anterior surface of the patella, and that's the reason why I call it the basket weave technique. Now once that is done, we go ahead with the fixation of the graft onto the extensor retinacular sleeves. The proximal graft limb is fixed by keeping the knee in 30 degrees of knee flexion and the patella centralized, and the distal limb of the graft is fixed by keeping the knee in 90 degrees of knee flexion and the patella centralized. And we need to suture the graft at every level of the sleeve. And what I prefer to use is a pretzel stitch, as you can see over here. So that represents the graft, that is the extensor sleeve over there, and that is the bone of the patella. So that's the vicryl suture. The first pass of the suture will transfix the graft onto the sleeve. The second one will loop around it, so it will help in cinching the graft. And the third pass will again transfix the graft onto the sleeve. So in one single suture, you are able to transfix as well as cinch the graft and hold it well without increasing the number of knots on the anterior surface of the patella. So there you see, that's the pretzel stitch, which helps us cinch as well as transfix the graft onto the extensor sleeves. So this is done at every level of the extensor sleeve. Once that is done, we just close by removing the redundancy of the first layer of the medial retinaculum there by suturing it onto the anterior surface of the patella. The excess limbs of the graft, of course, are cut off. And there you can see that it restores normal mobility of the patella. You get a very nice soft tissue endpoint, and it restores the normal tracking of the patella as well. If you see it arthroscopically, the entire reconstruction is extra articular and is extra capsular. And here you can see, as compared to the pre-op status, it has a normal tracking of the patella. So if you see the advantages that this technique provides, it is a fully anatomical reconstruction, both on the patellar as well as on the femoral side. On the patellar side, because it also replicates the soft tissue attachment, which is to the vastus intermedius, besides spanning the entire MPFL complex, it allows for differential fixation and differential tensioning of both the limbs of the graft in varying degrees of flexion. So it can replicate the normal physiological movements of the patella. At the same time, it will allow the patella to track normally as it would in a normal condition, which a rigid fixation would not allow. It allows for better proprioception because it has all soft tissue fixation. It avoids any over constraint of the graft, which is commonly seen in rigid fixations with bone tunnels and bone anchors. It has no bone tunneling in implants, so all their complications are avoided. It can be performed in the skeletally immature and in the hypoplastic patella, as in the pediatric age group. It avoids any radiographic errors because we are not using radiography at all over here. Resurgery is not difficult because it is an entirely soft tissue procedure, and it is an economical procedure. So in my case series, what I found is the Q scores have returned to almost normal, except for one case who had a patellar fracture due to fall from stairs, and she developed some amount of restriction of flexion. Otherwise, all the cases had their Q scores back to normal and could resume back to their sporting activities within about 4 months' time. So as we see, just to conclude, this technique has several advantages over other methods of reconstruction. It restores normal patellar mobility as well as stability. It lowers the complication rates of an MPFL reconstruction. It is a reliable and reproducible method, giving good to excellent results. So possibly a preferable method to be followed wherever MPFL reconstruction is indicated. Thank you all for your attention. Both the articles, the one in Arthroscopy Techniques and in Indian Journal of Orthopaedics, is an online open access journal, so you all can download it if you are interested in the further details. Thank you all for your attention.
Thank you so much, sir. It's a wonderful technique. So now we can take up the questions. Are there any questions? Okay. So Pranjal sir, so
Yes.
there's a question. So you said any specific complication you would like to attach with this technique that you would have found per se is important to be looked for your technique. Any specific complication?
I think one of the errors which I have heard someone doing is finding the ligamento-periosteal sleeve on the femur to be thin. That is an intraoperative finding that they've got. So the way to avoid it is very often we land up palpating the adductor tubercle, the medial epicondyle, and then land up, trying to go away a little from the joint, just trying to avoid maybe trying to go intra-articular. One may feel that, if we go to anterior, you might land up incising the capsule and going too much anteriorly into the joint. So usually that doesn't happen. You can safely go a little more anteriorly when you are taking the first sharp incision in between the adductor tubercle and the medial epicondyle. Feel the entire bump of the adductor tubercle and the medial epicondyle, and the area where it slopes down anteriorly, that's the region in which you need to take the anterior incision and then elevate the sleeve. And you'll surely find at least 1.5 centimeter of a thick sleeve in between the two. So that is one thing I think. Otherwise, I think if you follow the steps correctly, there is no other problem that I've come across or anyone else has told me they've come across.
Sir, there was a
one
tissue
small
elevator.
question for Pankaj. Sorry, one small question for Pankaj. Yes, finding the sleeve, I feel, with all of the techniques, is easier for younger patients. What about the adult? Is it that easy to find a sleeve to do this job?
Yes, I think because I've done one in a 55-year-old patient and I found good enough sleeves. So that is not really a difficult problem. Especially for the proximal one, there is absolutely none because you're almost going into the quadriceps. The distal one, the first medial sleeve is definitely again not a problem. The middle sleeve you might need to be a little slow and careful when you're elevating it, the distal one. But still you are able to get a thick periosteal sleeve over there, good enough to shuttle the graft under it and fix it.
Pranjal, if at all you have to err, so you should err towards the adductors or towards the medial epicondyle?
So if you palpate both the areas, I think you would not go wrong in going either ways because it's a large bump. And when you take the incision anterior to it, you would land up exactly in between the two. So there are techniques which are described both with the sling formed over the adductor magnus itself, but that again would be non-anatomical. And there are techniques which are described using the posterior third of the medial collateral ligament as well. But both these techniques are non-anatomical because they are not in between the adductor tubercle and medial epicondyle, where actually the MPFL inserts. So as long as you are a little more anterior, when you are elevating the sleeve, you are least likely to go wrong in that situation.
And what is this instrument, graft passer, which make and which company makes, and how to find that graft passer?
So like I showed you in my disclosures, Inomed is the company which is manufacturing the tissue elevator suture passer for me. And I do have royalties from them as well for that.
Okay, yeah. Thank you.
Debashish sir, there's a question for you. Hello?
Yes,
Debashish?
Yes, carry on.
So in your talk, you mentioned that there's a difficulty in getting a true lateral view to assess for trochlear dysplasia.
True.
So what's your take on replacing this X-ray, which is practically very difficult to be getting in any scenario, with a CT scan, where CT scan anyhow is going to gauge the dysplasia. So what's your take on that?
Well, only 6 years ago, David Dejour and Sagil, they have suggested this, and they, I'm sure, had access to 3D CT thing, but David's father, the Dejour, they preferred commenting on the trochlear dysplasia from the lateral view X-ray, and which I'm sure because they have given, you can, but again, they have mentioned this categorically in using a fluoroscopic, and it should be exactly lateral and it should be very good quality. Only then you can find the etc. Honestly, village with all the good all the time. So I'll go for 3D CT myself.
Vinay, one question to Dr. Rajeev and Dr. Debashish both and other panelists. Like first time dislocators, if you get sunrise view after injury, and if the patella is tilting and towards laterally, so should we go conservative or should we go ahead with the surgical intervention?
Well, sir, after the first time dislocation, the knee is painful, swollen, tense, as Rajiv has said. So getting a good sunshine view or the merchant view is difficult. In such cases, I'll do an X-ray epilateral, and if I have a slightest doubt about the possibility of a osteochondral fracture, I will do a MRI scan. That gives you much better idea of the position of the patella, including the lateral subluxation, etc.
Sir, Debashish sir,
Yes.
one question I would like to ask from you and Dr. Rajiv and Dr. Pranjal sir. If a patient is having patellar instability along with valgus deformity of knee, then what should be the approach?
I think alignment issue is very important, Ajay. So that is the most important part. So those are the indication where first time dislocator you have an alignment issue also. So you can plan for a correction of the alignment. And most of the time that works. So very rarely you need correction of alignment and the repair of the MPFL also.
Well,
Sometime you so you can plan for the alignment correction in those cases.
well,
Debashish sir, what is
I here beg to differ from Rajiv. In a primary case, even if there is a valgus and if that is especially bilateral valgus, then in the first setting, primary setting, first operation, I would not touch the alignment issue there. I'll still go by the soft tissue, that is MPFL reconstruction plus minus the distal bony realignment. But the realignment correction issues, I would not like to take primarily during the first operation unless it is a unilateral thing or a very complex case or a very failed case. In those sort of things, you think about the alignment issue.
And in these cases like bilateral valgus, majority of these cases, they have the 3D deformity, not only the coronal plane deformity. They
Exactly.
have the 3D deformity. You have to clinically examine, see the rotations, and then you plan the bony corrections.
Because exactly in such patient, the opposite knee, opposite patella is often stable, even with that equal amount of valgus. So why do you blame the poor valgus, bichara? That's my logic. Unless it is a second timer or a unilateral this thing. That is my feeling.
Pranjal, what's your take?
As a primary dislocator, anyways, first time dislocations with no other anatomical abnormalities, there is something called as the PISS score, which is there, which you need to do to decide whether it is a significant thing to reconstruct the MPFL in these cases. Once you've conserved them and they've come back with full range of motion, the swelling has subsided, we need to see clinically how they are. That is the first important part of it. If they are saying that still they feel instability, clinically also if the patella is dislocatable, when you are examining them even without anesthesia, those would possibly be the cases where you would need to intervene and do some procedure. MPFL, like I said, is the basic procedure which would be required for these. Now the question comes as far as the malalignment is concerned, whether we need to correct it or not. Yeah, it does become a kind of a dilemma whether we should intervene. It is not that one should not in any of the cases do a bony realignment when you are doing a primary MPFL reconstruction. We need to assess the patient as a whole and then know whether that particular deformity for that condition is significant to cause a dislocation or not. If one assesses, say, if there is a valgus of just about 5 degrees, which is bilateral, and the patella was not dislocating earlier, you would not do it. But if there is a valgus of say 15 degrees and the patella is dislocating laterally, then you need to take the call of doing the valgus correction at the same time when you are doing the soft tissue procedure, because you know over a period of time that soft tissue procedure would otherwise fail. So you need to take every case as an individual case and not generalize it for all cases. You need to see the severity of the deformity, what all deformities are there, like the previous speaker said, that there could be a rotational deformity, there could be a deformity in the tibial torsion or femoral torsion along with the valgus deformity. There could be a problem with the TTTG distance. So all these things together need to be assessed, and then we need to correct the ones that are significant for that particular case for the dislocation. It's not like for every case who has a TTTG with which is a little more than 2, maybe 22, that you are going to correct the TTTG by tibial tubercle transfer, or every patient who has, say, about 2 or 3 degrees of valgus, that you're going to do a valgus correction to neutral. Every case needs to be individually assessed and then taken a call, depending upon the severity and the significance to the dislocation.
But despite that, Pranjal, the overall incidence of doing a valgus correction in a primary first operation for recurrent dislocation should be much less. It should be done in a more often.
No, anyways, a surgical approach for a first-time dislocation is anyways going to be low. So the cases that you would operate for a first-time dislocator are anyways going to be low. You're going to first conserve.
No. I did not. Sorry. I get me corrected. Not first-time dislocation. The recurrent dislocation, which is first operation. That's what I meant.
Yeah.
A
So
recurrent
when it is,
dislocator with a first operation. That's what I said.
yeah, so when they do have a deformity, for example, if I would find a rotational deformity in these patients, which I do often find in patients with valgus and rotational deformities in females, and very often you get these dislocations in flexion. So if I find that the rotational malalignment is also significant, I would do the correction in the first stage itself. I would not wait for it to for my MPFL to fail and then do a revision of an MPFL with bony correction. It's best to give them a one surgery, which is going to give them 100% chance of non-failure.
Pranjal sir, so usually this scenario is bilateral scenario of valgoid knee. So once you correct one knee, so do you tell patient that the other knee is going to be corrected, because then we have an asymmetrical kind of thing. So one knee with a valgoid knee have a dislocation, the other valgoid knee has not a dislocation. So would you tell patient that we are going to correct both the knees, because then we have an asymmetrical kind of presentation of a patient?
So the patient needs to be well counseled about it. All these patients of deformity corrections always are well counseled and explained to what exactly the procedure is going to be, what will the limb look like, what their gait will be, and what will happen if the other side knee also has the same deformity. Now, this being explained, the patient knows that what is going to be happening to the gait of the patient post-operatively. If they have a significant issue with the gait post-operatively, then the other side may require a correction at a second stage, is what they are told beforehand.
Amaravati sir, Raj Kumar sir.
Yeah.
So do we have a relatively simpler procedure is lateral release? Do we have any indication of doing an isolated lateral release for anterior knee pain? Any indication that you follow in your practice? Isolated lateral release for anterior knee pain.
The only place where I can see that the room for lateral release would be the lateral compression, which is in isolation. There should be no other cause for that problem, except that there is a little lateral tightening of the retinaculum. Otherwise, I see lateral release for the subluxation of the patella or all those things is the waste. You should not be doing it because failures are high. And I am sure Pranjal will agree with me that the room for lateral release is not much, except that where the lateral retinaculum is very tight. That is only isolated case wherein they practice nowadays, I feel. Otherwise, we have to do in procedures and dislocation of the patella, as Pranjal's technique is aptly shown.
If I may just add on.
Also, may I add
one point about 20 years ago, ALRR, arthroscopic lateral retinacular release, has been very much in practice. We used to do that very often for any to find laterally tilted patella, and we will diagnose them as ELPS, as said by Falkerson, the excessive lateral pressure syndrome, and we would be happy doing a lateral retinacular release. But soon people found extensive lateral retinacular release in patients not always address the problem of the anterior knee pain. So you have to be very selective, and now people are, I believe. Yes, Pranjal.
Yeah, so I think he was speaking about instability cases where lateral retinacular release is not really indicated. What we are talking about now.
No. Vinay asked about anterior knee pain patients. For recurrent instability, it is of course not necessary. That is not. You asked about anterior knee pain cases.
Right. So for instability, we need to understand that that is not a procedure that should not be done, a lateral retinacular release. What, if at all, if you have a lateral tightness, what you should do is a lengthening procedure, not a release procedure, because we need to understand that when you release, you will be increasing the lateral patellar instability rather than stabilizing it further. And if you add an MPFL reconstruction to it, very often we have seen complications of increased medial patellofemoral overloading. At times it may lead to even medial patellar dislocation as a complication.
Absolutely.
So you should be very careful when you are selecting a lateral retinacular release in an instability patient.
Yeah.
Pranjal, can I ask you a question?
Yes, sure.
Yeah. Okay. See, you said there are issues when we try to locate the osteoperiosteal sleeve between the medial epicondyle as well as the adductor tubercle.
The ligament periosteal sleeve, yes.
Right. I wanted to jump in that time, but I think the discussion went on. So is there any other way we can do that? Suppose we are not able to locate that osteoperiosteal sleeve. Is the adductor tendon another site wherein we can loop the your gracilis graft or any other graft that you want to take and do osteoperiosteal sleeve reconstruction?
Yeah, so the idea of having this ligamentoperiosteal sleeve, which is in between the adductor tubercle and medial epicondyle, like I showed you in the diagram as well, that's exactly the area where the MPFL attaches. So that is the anatomical landmark of your femoral insertion of the MPFL. And you get a very nice thick sleeve over there with the periosteum, which can help us hold the graft. So it gives you a fully anatomical reconstruction that will give you a good result. Now there are techniques which are described already using the adductor magnus as the sling. So that is a technique by itself, using the adductor magnus as a sling to root your hamstring graft, or even using the medial collateral ligament as a sling to root your graft. So these are different techniques altogether. The problem is that these techniques would be non-anatomical on the femoral side. So we cannot expect an absolutely excellent result in these cases being non-anatomical. When you have a fully anatomical construct, you are expecting the best of results.
And both these MCL and Rasta's adductor magnus, these anchoring that were before the description of MPFL. They were there before. After MPFL,
yeah, these are old, yes, old techniques, yes.
Yep.
Now you are talking about MQTFL, correct?
Yes.
Yeah.
Yes.
So when you are doing your basket view technique, where exactly would you want to put your MQTFL arm so that you can take that also, or you want to, instead of doing only 2 limbs, should we do a 3rd limb so that we can take the MQTFL also?
No, I think when we are reconstructing, the proximal limb is almost at the superior border of the MQTFL. That is the proximal border of the MPFL complex. So as I showed you in the diagram, the superiormost fibers would decussate into the vastus intermedius.
Yes.
So when we are placing our graft, it is actually not on the patella, the proximal one. That's why I said the proximal ones, you will not have a problem with the sleeves at all. Even if it was an elderly patient, you are going almost at, you are at the superior pole of the patella, which is rounded. So you are going and weaving the graft actually into the extensor mechanism. And it's the distal sleeves which are at the distal border of your MPFL complex, which are on the patella.
Fair enough. Thank you.
So the proximal limb is representing your MQTFL.
Thank you. Thank you so much.
Dr. Pranjal sir, I want to ask a question. Have you ever encountered osteoperiosteal sleeve rupture in any of your cases?
No, till now I have not. So if you do the procedure carefully, I don't think you would land up rupturing. The proximal ones would definitely not. Like I told you, it is in the distal one where you are elevating the second sleeve over the anterior surface of the patella, the distal row. that is the area where you need to go maybe a little slower. Make sure that your 15 number blade is absolutely parallel to the anterior surface of the patella and elevating the periosteum along with it. And even then, because it's the periosteum that you are elevating along with the retinaculum, it is a strong enough sleeve, it will not rupture unless you cut it with your 15 number blade.
What is your rehab plan for the basket weave technique, Dr. Pranjal? So,
So the knee is kept in 15 degrees of flexion post-operatively in a knee brace, and the patient is up and about the next day. Till I remove the sutures, that is up to 10 days, they are keeping the knee brace on, and once that is done, I remove the brace. If they have got good quadriceps strength, I will just put them onto a kneecap, which is a lateral patellar stabilizer, and they can walk without the rigid knee brace. Once they get good quadriceps strength, they are able to do their SLRs, then they don't need the rigid long knee brace. The movements are started immediate post-operatively. The first week it's like around 30 degrees they're comfortable with. They'll get full range usually by about a month and a half. And they'll get back to sports. Some of them will get back to sports even in 3 months. Some will get back to sports in about 4 months' time.
So thank you everyone. I think we have long overshoot the time that was allotted to us. So is there any other question or we can wind up? So thank you OrthoTV for giving us a platform to discuss all this and have these stalwarts with us to educate us regarding patellofemoral issues. I would invite KD sir, kindly say a few closing remarks to close the session. KD Tripathi sir.
I think, thank you, Vinay. It was a wonderful show that we have overshoot the time. That is how it was very interesting session. Dr. Amaravati just told us in detail about the anterior knee pain. It was a mix of surgeons, like a few of us are doing arthroplasty and arthroscopy both. So anterior knee pain in the arthroplasty point, I wanted to ask you a question, but I think this is the meeting of arthroscopy, so I didn't go that. There is anterior knee pain in the arthroplasty is a very difficult problem and it takes long time. So I think Dr. Amaravati, we will discuss sometimes later the anterior knee pain in the joints and in the ACL as well. It's a very long topic. So that how, because Dr. Pranjal has given very good techniques. So majority of the time we discuss that, because initially it was medial reefing and lateral releasing, then MPFL came, and this is new innovation and the very good innovation. I think the problem with this one is that when how to calibrate this tension of the MPFL when you are reefing both the tails on the patella. Few words, Dr. Panjal, can you just say that on?
See, the MPFL is not like your other ligament reconstructions like your ACLs and PCL, where you pull totally hard and try to fix it in the maximum tension position. MPFL is something which doesn't require a lot of tension. So as long as your graft is taut enough and your patella is centralized, which you can ensure by making palpating the lateral border of the patella, which is flush with the lateral border of the trochlea as well. So you know that the patella is centralized. Pull onto the graft. You don't need to pull really very hard. It needs to be taut enough, and then you start with your suturing. Once the suturing is done, you can again re-examine and see that the patella is not dislocating. It should not move more than 2 quadrants. And once you've got that, you know that it is in place. So there is no way that you can over tension the MPFL using this technique, because you are fixing on the patellar side after the femoral fixation. So you don't need to be worried about that.
And thank you.
Can I just make a small comment there, KD sir?
Yeah.
This is exactly what we use for any MPFL. It should not be too tight. You should have a side-to-side lateral play. With at least 1 quadrant of the patella should be able to go beyond the lateral margin of the lateral femoral condyle, and your knee should be able to be bent up to 70 degree or 90 degree. Then you know you have not done too much tightening.
Thank you, Dr. Debashish, and your lecture was quite elaborate, and you give the overview of recurrent dislocation of patella, including the soft tissue, the bony, the trochleoplasty, everything. And our young chap, Dr. Rajeev Raman, on the first-time dislocators, he has given very great overview. Along with all, I thank you all because of the process time. We need to discuss many more questions, but I think time is not allowing us. Thank you, Dr. Vinay. Thank you, Dr. A.N.Verma.
Thank you,
Thank you,
thank you,
OrthoTV.
Vinay. Thank you, Keddy
Thank
sir.
you.
Thank you.
Thank you, OrthoTV,
Bye,
for
Dr.
giving
Ashish.
platform. Thank you so
Thank
much.
you, everybody.
Good night, everyone.
Ajay.
Good night. Good night.
Good night.
Thank you. Sure. Thank you so much.
Supratim, you there?
Hello.
Supratim,
Hello, Vinay sir.
we live. It's still live, I think. Supratim, thank you so much, sir.
Hello.
भाई अजय, हेलो, चली गई आवाज, आवाज नहीं आ रही। नहीं आ रही आवाज यार।
मैं कह रहा हूँ गुड नाइट सर।
हाँ, गुड नाइट, बढ़िया रहा यार।
हाँ,
था थोड़ा,
ठीक
लेकिन अच्छा रहा।
ठीक
चल,
ठीक सर।
ओके।
ओके, गुड नाइट सर।